So the usual intro stuff. This slide here just says no one involved in these trainings have any relationships to disclose. And our usual funding statement, again, we're funded by federal grant from SAMHSA by way of Nebraska DHHS. And then usual process for CME certificates. An email will come out to you all before noon today with a link to an evaluation survey. I'll also drop that link in the chat towards the end of the meeting here. Just do that quick survey and certificate will come up automatically. Again, call or email me if you have any questions or issues with that. So this is our last ECHO training in this current cycle. We do these in groups of 4. So this is the 4th of the 4 in this current series. We'll be off in March while our experts plan for our next round of trainings, which will look like this here on this slide. We've got a few presentations from Dr. Massey. Ed's doing one on kratom, xylazine, gas station heroin. Should be a good series. You'll note in the evaluation survey from last time and from this time, you can automatically enroll through the evaluation survey in this next series of trainings. If you'd like to do that, just check the box in that evaluation survey, and then I'll, if you do that, I'll follow up next week with a confirmation of registration. Just to keep it simple, and for folks who, we have a lot of folks who kind of just keep coming back, so hopefully that makes it a little easier. You don't have to keep an eye out for that separate registration email. You can just do it right through the evaluation survey. And so with that, I'm going to let our hub team introduce themselves, and then we will turn it over to Stephanie. Let's see, Janet, would you like to go first?
Yeah, I'm Janet Bernard. I practiced family medicine in North Platte and have recently retired, used Suboxone for opiate substance use disorder for years.
Ed, would you like to go next?
Yeah, good morning, everybody. Ed Kaiser here, nurse practitioner, family medicine trained, been working in addiction medicine for almost 6 years now. So glad to be with y'all.
Thanks. John?
Good morning, John Massey. I'm a pain physician in Lincoln. I have used quite a bit of buprenorphine in that context.
Gail?
Good morning, I'm Gail Keller, and I'm down in Falls City, Nebraska.
Thanks, Gail. And Stephanie, I'll let you introduce yourself and take charge.
Sounds good. I'm Stephanie Bennington, psychiatrist, primarily located in Omaha. I currently see patients in 10 states, soon to be 12. But I primarily see patients both in hospital EDs and primarily specialize in substance use, but really I see everything at this point. So we'll get right into it. I just need to share my screen. There we go. Can everybody see it okay?
Looks good.
Okay, great. So today we're gonna get into marijuana and analogs. We're gonna discuss some of the basics associated with cannabis, the different parts of it, whether it's THC, CBD, and kind of discuss how it relates to the medical field in general. Some of the objectives that we're going to learn today are we're going to discuss, as I mentioned, cannabis, marijuana, the THC versus CBD, its current use and trends. We'll describe some of the routes of administration, effects, actions, potency. There's a lot of different terms thrown around regarding cannabis, Delta 9, Delta 8, Delta 10. We'll kind of examine that to clear up any unclarity in regards to what people currently use. We'll discuss also current uses in medicine for CBD, and then we will review the treatment for cannabis use disorder. So starting with some of the basics, we'll kind of break it down a little bit of biology here, taking it back to biology 101, to truly understand about the cannabis plant itself. So there's different strains Cannabis sativa is the typical marijuana we think of when we think of marijuana. It's the spindly long leaves. It's this type of plant is generally found in regions closer to the equator. And why this is important is because of the fact that it has in the regions near the equator, these plants will see a constant and consistent amount of daylight hours. So it never really ranges throughout the year. And so why this is important is that, well, when we think to Nebraska, you know, our growing cycle is primarily in the summer, regardless of what plant we're talking about. And so plants are designed to grow to a point and then to flower. So plants will generally stop growing when they flower, and it'll spend all that energy on the flower itself. Well, cannabis sativa is different in the fact that since it does have this constant daylight, it's used to actually growing and flowering. And because it still continues to grow while it flowers, it produces much higher levels of THC. And so this is why this is the most sought after plant and why it's the one with the highest THC and generally the most misused. And so when we think of and there's some different strains other than these ones, but these are the most common when we think of cannabis. So cannabis sativa is generally going to be your high THC content. Your cannabis indica is going to be the plant that is the more in more of the mountainous region. So it'll stop essentially growing and then it'll flower. So due to that, it's going to have a lower THC content. It's also going to have a more proportional CBD content as well. And it generally produces smaller plants. So when people are mass producing it or trying to produce it illegally, like in their basement, they're generally going to be trying to produce the cannabis indica plant. Cannabis ruderalis is a combination of the two. It's actually really unique in the fact that it can self-pollinate. So a lot of manufacturers will try to cross cannabis sativa with cannabis ruderalis, and then it essentially auto populate itself, and it's a really low maintenance plant. Cannabis ruderalis on its own has a very low THC content, much higher CBD. So this plant is generally not going to produce the excitatory effects that you would see with plants having higher THC. So that's a little bit of biology 101 regarding the plant itself. Now we'll kind of go into what I mentioned with the THC and CBD. So when we talk about THC producing effects or producing, a high, we're generally referring to delta 9. So everything always kind of refers back to delta 9. When we're making these comparisons, it's always back to delta 9. Delta 9 THC is illegal federally and on all state. Federally, states whether it's legal is dependent on states itself. Nebraska, it is illegal, but federally it's still not legalized. When we talk about delta 8, delta 10, these are variants of the cannabis plant itself. They're generally derived from the hemp plant, and a lot of you have probably heard terms, okay, hemp, THC, cannabis, marijuana, what does all of this mean, right? And essentially it's all different names of kind of the same thing, right? I'll kind of break it down just, as I go through this lecture, I'll be making references back to these words. So I'll kind of break it down here first. So overall word that we'll use is cannabis. Marijuana is kind of the lingo that was used back in the day. It has kind of a negative connotation against it. We try not to use the word marijuana because there is stigma associated with it. And, I'm thinking back politically, and I don't recall exactly the president, but when it was originally brought forward in the United States as this being a problem, the term that was used to describe it was marijuana, to have it associated with ethnic origins from Mexico, that they were bringing it up and this was an issue. So it has a lot of negative connotation associated with the word. So we try not to use the word marijuana, try now to use the more appropriate word of cannabis. Based off of the actual name of the plant. So cannabis, marijuana, essentially the same thing. Then we talk about delta 9, delta 8, delta 10 THC. So that's referring to the actual THC concentrations. And then we have CBD. CBD is essentially referring to no THC content, but I'll get into that a little bit more. So looking at these, delta-8 THC, it's naturally found in cannabis, but it's a small amount for the actual THC content. This is federally regulated, so we're talking about like less than 0.3% per federal regulations of what is allowed to be in THC or to be in CBD, and it tends to produce a less intense high. It has with less anxiety, and this is typically the form that you're going to find in gas stations or at a convenience store. If it says, you know, this is cannabis, or this is weed or marijuana, whatever the term that they are able to use, that they want to use, this is generally the type that it's going to be, is the delta-8 variant. Delta-10 is similar to delta-9, but it's less potent as well. And so it can produce more of the psychoactive properties that we see with delta-9 THC. And listed on the side are some others, not necessarily legal, but some of the ones that are except in states that are approve it for medicinal purposes. But some of the examples over here, just for information purposes, if you've seen them, are like HHC, THCP, which tends to be very potent. Then you have the most potent in this form is the THCO acetate, and that actually is 3 times stronger than delta-9. It tends to have these LSD-like effects. You get this false sense of perception of time and space. It tends to lead to psychosis, things like that. So this is more just reference kind of terminology. When we think about cannabis potency, we have to look at both the THC content and CBD content, the cannabinoid. And so both THC and CBD are both parts of the marijuana plant itself. So when we think about THC, we're mainly thinking about the actual flowers. That's where the concentration of THC is going to be highest. CBD is found in kind of the aerial parts of the plant, such as the stalks, flowers, but also in the leaves and the flowers itself as well. So the concentration depends on the variety of the plant and the strain. But if you look at this chart, you'll see how over the years we've kind of switched between having a higher CBD concentration to it's gradually decreased, and then THC concentration has increased. And this comes with cross strains that we've created. How I mentioned how they've been cross straining with the cannabis sativa with that ruderalis plant, and you generally will produce higher concentrations of THC. So it's the evolution of the plant itself. In order to actually get delta-9 THC, so remember I'm referring to the more of the psychoactive, the high properties when we think about it, the one that's not federally legal. Delta-9, in order to extract delta-9, it actually requires a good amount of reaction in order to do it. So you're kind of doing this like chemical reaction in order to get it converted over. So it requires a chemical synthetic to convert it, and then it requires the THC acid to be converted over delta-9. So it usually uses heat conversion in order to do it. And THCP is actually a really rare cannabinoid. It's synthetically made. So these are absolutely synthetically made, and it's extremely potent variation, about 30% more potent than actually delta-9. This is a list kind of showing all the medical conditions that cannabis is actually approved by states. And the list is extensive. And there's the research is the best word is inconsistent. It really is depend on the condition. But as you can see, there's quite a bit that is actually approved for medicinal cannabis. There are multiple cannabinoid receptors that are located throughout the brain, and this is essentially where THC and CBD have target. So as you can see, it has a lot of different areas of the brain that it affects. And so hence the reason why for the extensive list of why it's medically approved. So cannabinoid receptors themselves are important in brain development, memory and cognition, pain regulation and anesthesia, immunological function, appetite, motivational systems, and reward. So this is why we generally will see such robust effects with THC and CBD. And this kind of gives you more of a visual of how much of where these cannabinoid receptors are spread even throughout the body, not just the brain. So it has a lot of cannabinoid receptors are present throughout, and so hence why we see such a wide range of the effects that cannabinoids and THC have on the body itself. So now we'll get into kind of some of the routes, and I'll mention a lot of the words and the lingo that I'm sure everybody has heard used. Let me make sure I minus this. Okay. Some of the routes that we commonly hear today are like vaping, which is usually done with oil or wax, which is usually with the plant bud itself. It can be smoked. There can be oral methods, liquids, capsules, lozenges, edibles, and then concentrates. So we'll go into these a little bit more detail. So one of the most common routes is through smoking, and there's many different ways that cannabis can be smoked. So it can be with a pipe, and I kind of gave brief definitions here on what those actually are. And so generally all the methods for smoking is you create this vapor that essentially you can inhale. And so it can be through blunt, rolling paper, pipe, bong, hookah. But the important aspect of this is the standard dose is about 1 milligram of THC. And so this will be important as we kind of compare the different routes here. Now we'll talk about hashish. This is generally a more concentrated version of concentrated THC. So it tends to produce more of those psychoactive resins. So you get more of the psychoactive properties associated with it. Hashish is generally smoked in a pipe, and to kind of put it in comparison, as we just talked about with smoking on the previous slide, was the standard dose was about 1 milligram THC, and so hashish is about 10 milligrams. So just to kind of put it in perspective, the difference in concentration here. Edibles are pretty similar in that. If I should preface that by saying, if the person who is making the edible understands the chemical process of extracting the THC itself, but it generally produces standard dose about 10 milligrams of THC. Some examples for edibles are cookies, brownies, candies. It is a concentrated hash oil, and it has a high THC, so similar to hashish. This, people, a lot of college kids will try to obtain, cannabis, and will think that, just putting the plant itself into, some cookies and then baking it essentially produces it. And that's not how it works. You have to actually extract the oil through a heat extraction process, and then use that oil to essentially bake it into whatever is being used for the edible. We'll talk a little bit about concentrate. So these are more, as the name suggests, much more concentrated than smoking or hashish. So some names with the concentrates are like earwax, wax, dabs is a method for concentrating it and being able to inhale it that way. Shatter, honeycomb. These are, you probably haven't heard of all of them, but some of these names ring a bell. Dabs are the high grade hash. You have the wax, which is more of like a soft, opaque oil. The extraction from cannabis via solvents, such as like butane, the common name for this is a butane hash oil, will produce a much higher concentration of THC itself. And so the standard dose of concentrates is about 40 milligrams of THC. Shatter is an example of a cannabis concentrate. It's named for its it's got this hard glass-like consistency, and it's called shatter because it will shatter when it's broken apart. It's gold amber in color, almost honey-like color, and shatter is usually used by dabbing. And so dabbing is a method that essentially uses this flash vaporization process. And you have to have a specialized like dab rig or a pen in order to heat it that quickly and that high of a temperature. And so dabbing has a long history of how it's, you know, changed to what it is today. I think one of the first methods used was essentially creating this very hot knife and then putting the cannabis on it and it basically increasing the temperatures to high levels very quickly. And it's kind of evolved since there and from there. And now there's actually dab rigs and pens specifically for using this type of cannabis at very high concentrations. And when you actually test extracts of shatter, it can test upward of 80 to 90% THC to kind of put it in perspective. So this is significantly concentrated compared to, you know, what we have known to be as THC. Some of the synthetics that we hear associated with cannabis is spice, K2. We hear that a lot around here. Fake weed, ditchweed. Is some of the name. Ditchweed can also mean another variation. There's more of an old lingo, but it's making a comeback, and ditchweed can be associated with it as well. Herbalist incense. Synthetics are manufactured in labs. It's basically synthetic CB1 agonist, so it's acting on those cannabinoid receptors. And when these synthetics are extracted, they're generally sprayed onto the marijuana or plant material to produce the effect, and then it's typically smoked. So it's a way to get more of the THC psychoactive effects that people that people seek when they're looking for cannabis. Some of the current research, actually a lot of the research does support positive properties in cannabis. And a lot of it comes down to pain and other symptoms, especially caused by cancer and cancer treatment. One of the probably most well-known effect is nausea secondary to chemotherapy, that it has significant benefits of helping with that. It can also help with chronic pain associated with multiple sclerosis, and there are studies specifically supporting that. Other benefits are with AIDS and glaucoma at high doses, but it was not a robust effect. So the FDA has actually approved certain types of cannabis for therapeutic uses, such as I mentioned with anorexia, with weight loss in AIDS patients. It's from a synthetic form of actually Delta-9, and that's able to create that psychoactive component of cannabis that actually creates that improves the nausea and helps with increasing appetite. Go on from there. So talking a little bit about the onset and length of action, it really depends on the route that the person is using cannabis. And this is essentially the same for all of our substances. Smoking or vaping generally produce the effects within seconds. Duration can last 1 to 3 hours, depending on the strain and the method that is used to smoke or vape. Oral the effects tend to come on later, about 30 minutes to 2 hours, and the duration can last anywhere from 4 to 10 hours, really, again, depending on the extraction method and the type of oral and the type and what it's essentially put into. So whether it's edibles, whether it's like a liquid, that's what kind of creates the variability in the duration of action. We kind of already mentioned this, but I wanted to kind of give a little bit more details on some of these effects that we see. And this is generally the case in across substance use disorders. It's not specific to cannabis, but why it's important here is that the CB1 receptors, our cannabinoid 1 receptors, are high in our areas that we commonly see with substance use disorders. 10, 15 years ago, there was the common thought that, that cannabis isn't addictive. I can stop it at any time. This was the common mentality. And there wasn't really a ton of research to support otherwise. But as more research shows that our cannabinoids or cannabin receptors are concentrated in these areas of addiction, we do see that cannabis acts the same as other substances and creates the same addictive properties that we see with other substances. So our prefrontal cortex, ventral tegmental area, kind of going back to biochemistry and understanding this reward pathway. Nucleus accumbens is probably one of is the most the one we probably all think of when we think of addiction, because the nucleus accumbens is the area of the brain that creates the rewarding effect, that euphoria, the dopamine, the craving. And so then it creates this feedback within other areas of brain involved in learning, memory, what we term as drug-seeking behaviors. We've heard that term before. It feeds back on all of that area, so it creates the same cravings and the same actions that would make somebody want to go out and use more of the substance. It has the same withdrawal it has the same withdrawal pathway. So people that stop using cannabis will not feel good. They'll feel depressed, they'll feel sick. And so then the whole system kind of feeds back on itself to create the substance use disorder, as you can kind of see in the picture. So when talking about some of the effects of cannabis itself, it depends on, as I mentioned before, the strain, and it also depends on the concentration of both CBD and on THC. When we're talking about just THC itself, THC at high concentrations is the part of the substance that actually produces that euphoria-like effect. It's psychoactive. It can lead to reward, enjoyment. It generally decreases anxiety, relaxation, and some of some other effects that are seen as pleasurable is this change in perception of time. And so in sensory perception. And so time kind of slows down. Colors can become more vivid. Space and time itself are altered. And so that can create just this overall sensation of relaxation with it. Some of the adverse health effects, these are ones that we're now seeing much more, we're seeing now in research. We have a lot more research to support the adverse effects, especially in teens. The risk of addiction is high. It's 9% generally, but it's much higher if cannabis is started as a teen. And I don't think this is we don't make this aware as much as we should, or there's just not an overall understanding of how much this is increased when cannabis is used as a teenager. This risk increases to 15 to 25%, which is significant. And this is why we need to increase more of awareness, especially in this teenage population. Because it's so commonly used, it's commonly available, and reducing teen use so that we don't increase this risk. It affects brain development. As I mentioned before, cannabinoid receptors are present throughout the brain, and they're involved in brain development. And so with that, when these teens and kids are using it, when they're still actively in this brain development process, it impairs the functional connectivity, and impairs the connectivity, impairing self-conscious awareness, memory, and learning. All of this is significantly impaired and can affect actually long-term development of the brain. We see anxiety with, depression, long-term use, psychosis. We get the risk of motor vehicle accidents, and this involves, this goes back to the perception of time and space and to be able to react appropriately. School performance is reduced. Overall lifetime achievement is actually reduced. It can lead to cancer, chronic bronchitis, particularly when the method of use is through smoking or inhalation. And there's an increase in drug-related ER visits associated with it. So looking at some of the adverse cognitive effects of it, this kind of goes into it a little bit more detailed on what areas of the brain we're looking at. So less control of emotions. We're thinking more of the frontal cortex. It's the area of the brain that's not developed in teens, not developed in teens until, early 20s to middle 20s. So it affects the ability of people to be able to think quickly. They have impaired judgment and decision making. It decreases motor performance and coordination, decreases inhibition and impulsivity, attention and concentration, and ability to hold, manipulate, and store these memories. And so being able to recall previous memories is significantly impaired as well. And this is generally why we see such impaired performance with school as well, because they're just essentially, using cannabis, especially before school, going to school, they're not going to be able to retain any of the information that was presented to them. This is a study from 2012. However, it's still, prevalent and important in recognizing, but cannabis use disorder is linked to significant IQ drop. In the research that we've had since this time further supports this. This graph, it just shows how significant this is for increasing awareness so that we don't get children exposed to it at an early age, especially in teenage years, because it's a pretty significant drop. Multiple studies have also showed altered brain structure and function in youth who regularly use cannabis. So we're actually we're visually seeing the changes in the brain itself. So we're not just measuring it through behavior changes or IQ, testing reaction performance using cognitive-based tests. We're actually seeing the physical damage on brain scans as well. Psychosis is one of a common side effect that we see with consistent and early cannabis use, especially in adolescent males. And this, people can kind of read the overall conclusion related to this study, but it essentially increased paranoia and hallucinations by 133% and 92% when comparing it to regular cannabis use for each year that adolescent boys used cannabis. So this is significant. 133% and 92% is significant. These are huge numbers that we're seeing with cannabis. So taking this information and applying it, in providing education, because I think a lot of people still tend to think, cannabis is natural. It's found in a plant. How much harm can it actually cause? That's still kind of the mentality of a lot of our patients. And the truth is it can cause significant issues and can significantly alter the brain function. So, it's our job to really bring forward this information so that they understand it and truly have a good understanding of what it can actually do. This kind of puts it in graph form regarding the psychosis. The graph kind of speaks for itself here. The more times that cannabis is used, generally, the more side effects, the more significant issues that we see. In the first graph, the bar graph there, we see, the number of times that cannabis is used. And above 50, we generally see this much higher spike in cannabis-associated psychosis. And on the one underneath, the risk of schizophrenia like psychosis at age 26. So this goes back to why it's so important that we're bringing recognition to teen use, because cannabis users that used it prior to age of 15 have a higher percentage of schizophrenia like psychosis by the age of 26 compared to individuals who used it age 18 or later. So this kind of just further solidifies the need for bringing awareness and understanding to the general population. Again, this kind of another graph from a K 2021 that really just re-solidifies what daily and frequent cannabis use does. So risk of psychotic disorders increases with daily cannabis use, particularly if the THC content is above 10%. So when we're thinking about CBD versus THC, generally worse psychotic episodes and disorders when we have a high concentration of THC. Another concern that we have associated with cannabis is the withdrawal. I mean, this is a concern for all substances. And this is something that we need to be aware of, because cannabis withdrawal is going to make patients feel terrible, as with any other withdrawal symptoms. But with cannabis, especially in the teen population, they especially don't really understand why they're feeling that way. And when they feel so terrible after they stop using, then they get into the mind frame, oh, it was helping me, so I should go back to using it. And so this, again, where education becomes really important here. But what we typically see for cannabis withdrawal, day one, we see essentially everything that they claim it helps them with. We see the opposite effect. So we see insomnia, irritability, decreased focus, anxiety. By day 2 to 3, we get headaches, cravings, sweating, chills, decreased appetite, nausea, vomiting. Day 4 to 14, we get more of the depression symptoms, the mood issues, more of the craving. And then by day 15, we actually get worsening depression, worsening anxiety, and insomnia. And this can go on for months, that they can continue to have these effects. And so, but by day 15 is generally when we get more of those significant mood symptoms. So a common presentation that I frequently see, especially is with teen populations, is in the middle of the night, I'm frequently getting called to see kids coming in with increased depression and anxiety and suicidal thoughts at 2, 3 o'clock in the morning, because they can't ever sleep. And this is usually within 2 weeks of stopping cannabis use. And parents don't understand, because they're happy that their kids stopped using, and then they wonder, okay, well, particularly in states that do allow medicinal cannabis, they will frequently ask me, well, my child has been off of this for 2 weeks. Do you think I should look into getting a prescription for them for medicinal cannabis? Because I didn't realize how bad their depression and anxiety was before. And this is frequently thought by parents, because they want their kid to feel better. They don't want them to feel like this. And they kind of forget how their symptoms were prior to their cannabis use, because generally the child may not be upfront initially. It may take some time to fully tell their parents, what they're using and how often they're using it. But even with that, even when they have full awareness, they'll generally think, oh gosh, maybe this was actually helping my kid. And maybe I should get them on this on daily use. And so I frequently have to kind of go through the education part, and in that, the mood symptoms will significantly worsen about 2 weeks. And so this is expected, and it doesn't mean that, that parents should, be looking for getting them a prescription for cannabis. And that would not be recommended. Some of one of the significant issues that we see with long-term cannabis is the hyperemesis syndrome. So as I mentioned before, it can help with nausea, vomiting. It can help with appetite. With daily use in high concentrations of THC, we get a disruption of this, and we actually see the reverse happen. So when somebody is using months up to a year, depending on the person and how they respond, and depending on the THC concentration, we we can have normal eating habits, and then they will switch into more of vomiting, nausea, and then it makes them use even more to try to prevent the effects. And then maybe it'll help for a short term, but then they use even more. We'll commonly see compulsive hot showers and baths and abdominal pain. And so then when the person stops using it, it takes a significant amount of time to recover from this. But eventually those eating habits are restored and they will feel better. But this can take days, months in order to actually get to this recovery period. Now we'll kind of switch into a little bit about CBD, as I mentioned before, cannabis oil. And remember, this is also part of the cannabis plant. It also works on the CBD receptors just as THC does. And CBD is in a lot of products. I guarantee that we've all been in the store and seen the products that have CBD, drinks. It's in lotions. It's in health, quote unquote health drinks, healthy foods that that's marketed as CBD. It's even in like coffee drinks. It's in ice cream. It's in a lot. You can go on Amazon and Google it, or go on Amazon and put in CBD, and you'll be impressed on all the different ways that CBD has been put into products. So CBD itself is also interacts with both CB1 and the cannabinoid-1 and cannabinoid-2 receptors, just as THC does. But this is a non-psychotropic effect. So it's derived from hemp plant. And just to kind of give you an understanding of what hemp, what we identify as hemp. So hemp is actually a federal term passed in 2018 that from I believe it was the Farm Act, that it's essentially, hemp is essentially the cannabis plants that have THC less than 0.3%. So that's what we refer to as hemp. But CBD is derived from those plants, is what we commonly see from the market. It can be in edibles, oils, extracts, vapes, you name it. There actually is one approved medication that is highly concentrated CBD, in its pure form, and it's called Epidiolex. And this actually is used to treat seizures in children. It was actually a controlled substance until I believe it was 2020. Excuse me, Epidiolex. I mispronounced that. Epidiolex. It was controlled until I believe it was 2020, and then the FDA actually removed it as a controlled substance. But it's used for the treatment of seizures in children. And there's studies ongoing for various medicinal and psychiatric uses of CBD. And I'll try to get through these relatively quickly so we have time for questions. So what is the difference between CBD, medical cannabis, and hemp? Well, it really comes down to the strain and the concentration. So cannabis oil, or CBD, is the lesser known of the cannabis sativa plant. And so this is the part that we talked about does not actually have that psychoactive properties. When CBD and THC are combined, CBD actually modulates the effect of THC. And so, I want to make mention of this so that there's more understanding of those two. So when we have CBD and THC, and both of them are in the strain that is smoked, whatever method, CBD is going to modulate the effects of THC. So it's going to modulate in it's depending on the person on the effects it's going to have, but it's going to basically diminish the psychoactive effects. And so the two combined are actually going to create different symptoms than if CBD by itself and then THC by itself. So CBD is, as I mentioned, cannabinoid found in cannabis and hemp plants in varying amounts. It's considered non-intoxicating constituent. Medical cannabis or medical marijuana generally refer to the use of the cannabis plant or cannabinoids to treat medical conditions. And it will have varying amounts of cannabinoids like CBD and also varying amounts of THC. As I mentioned, hemp is the species of a cannabis sativa plant, and it was originally cultivated for industrial use. It contains, as I mentioned, it has to have 0.3% THC by dry weight in the United States, and these are federal regulations. And it generally has larger amounts of CBD to be considered hemp. You know, when we're talking about the federal regulations of that 0.3%, the federal government doesn't control if it has to have 0% or up to 0.3. So this is important, especially to tell our patients, because when somebody is taking CBD for, you know, anxiety, for whatever reason that they're using it for, they can have the whatever variety they're using can have up to 0.3% THC. And so we will commonly see urine drug screens that were screened positive for cannabinoids. And I want to make this clear that it's not actually screening positive because of the CBD. So CBD should not actually screen positive for a cannabinoid, because when it's testing for you know, cannabis and THC. The reason why it's screening positive is actually because of that THC, that up to 0.3% THC. So a lot of patients aren't aware of this, you know, particularly if they're in jobs that are getting urine drug screens. So increasing education that this can actually screen positive for cannabinoids. And then last thing to note, CBD is extracted from hemp using several different methods. And as I mentioned before, kind of a similar way with THC. But it can generally, you can use more varieties of the actual plant that you wouldn't be able to get with THC. Again, common ways that CBD can be used are vary depending on the person's preference. All, you know, smoking, vaping, capsule eating, all the similar, even ointments and lotions. At moderate doses is about 200 to 800 milligrams. And at these doses considered moderate, has not been shown to have significant addiction. And so this is important to note that, you know, research has kind of supported that this dose is considered moderate, not a significant addiction potential. It generally has a favorable side effect profile. And as I mentioned, the only pure form of CBD containing product is that Epidiolex. It's plant-derived, highly purified form of CBD. It does not have any THC in this, and it's the only thing that medication that you can receive that ensures that there will be no THC associated with it. Again, as I mentioned, it's no longer scheduled. It's approved for the treatment of Lennox-Gastaut and Dravet syndrome, you know, seizure disorders. It's available. As I mentioned, it's not regulated or overseen by the FDA, and or the commercial products that we see in stores, gas stations. They're actually not commercially regulated or overseen by the FDA, which is why they can have up to that 0.3% of THC. Epidiolex is regulated by the FDA and cannot have any THC concentration in the product. So just to kind of put it in perspective. So this kind of looks at the symptoms between the two of THC and CBD. And when they're together, it kind of the CBD will modulate the effects of THC, but when they're separate, we generally see the psychotic symptoms mostly associated with THC. This kind of goes back to what we originally talked about in the beginning. The strongest evidence that we have in our medical literature is for pain, especially that neuropathic pain. But we do have studies that support the use in nausea, as we mentioned, appetite stimulant, some evidence in anti-inflammatory, anticonvulsant. The weakest evidence is associated with PTSD, ADHD, Alzheimer's, and depression. And I'll quickly go through this. This is just a better slide that kind of explains truly the effects associated with the chemicals. When we just have THC, we just see that reduced pain, reduced stress and anxiety. Negative effects are the heart rate, blood pressure, that reaction time, coordination. We generally have more of the psychosis, delirium, aggression. When the two, with both of them, we see that substance use disorder. Psychosis is with both. anxiety, pain, inflammation. Oh, excuse me, I said that wrong. Psychosis is generally improved with CBD. Anxiety is generally improved with CBD, and generally worsened for both of those with just THC, higher concentrations of THC. Some negative effects of both still are we're going to have substance use disorders because of the THC, psychosis, anxiety, and of course the negative impact on the developing brain associated with the THC. And lastly, we kind of mentioned this in the 2 lectures ago when we talked about the non-pharmacological treatments for substance use disorders. These apply here as well. So we have the motivational enhancement therapy and helping patients with cannabis use disorder, cognitive behavioral therapy. And remember, if you were here for that lecture, with cognitive behavioral therapy, we're not trying to bring insight. We're not trying to, we're not trying to develop that insight in that person. That would require much more extensive psychoanalytical therapy, and that's not what our goal is when we're looking at cognitive behavioral therapy. We're helping the patient change the way that they're thinking when they have those initial impulsive thoughts, where that kind of leads them. If I'm anxious, I'm not good enough at this. I don't, I can't do this without cannabis, and that negative thinking then reinforces the behavior to use. So cognitive behavioral therapy will alter that train of thought. So when they get those impulsive negative thoughts, then teaching them to start having kind of a stream of thought in their head that makes them not want to go to cannabis. So it's an open dialogue. Really, you're allowing them to be the expert in their own consciousness and just asking the questions. So you're not leading a patient, you're just kind of asking them, getting to them to understand their own thoughts. Then we talked about before, which again applies for all substance use disorders, is contingency management, giving them these positive rewards, something to look forward to, that makes them not want to use. And then of course, as we mentioned, with adolescent use being a significant issue, particularly with long-term brain development, we have the adolescent community reinforcement approach. And this is really kind of focusing on this population, increasing awareness, increasing understanding, getting these adolescents to not continue use, so we don't have these long-term brain development effects that alter the course of their life. And of course, family therapies. And this is especially important, for all substance use disorders, but especially in that adolescent population that's using cannabis, getting families involved in it, getting them to understand, what we will typically see in the moods and behaviors of these kids when they stop using, getting them the support, figuring out what they need from family and having them all kind of work together to truly help the patient with their cannabis use disorder. And then lastly, we really don't have any treatments approved for cannabis use disorder, but the research supports that some of them do seem to work. Not great, but they work. N-acetylcysteine is a common one. The research shows that it increases the cessation when added to the contingent management therapy and behavioral treatment in teens. Gabapentin is one that is used, and it helps with the withdrawal and craving, but this is when the doses are at 1,200 milligrams a day. I'll commonly see this used, which is great. I love it when this is used, but a lot of providers are really uncomfortable prescribing it at the levels that are needed to actually see a positive effect, which is a minimum of 1,200 milligrams a day. And gabapentin actually has been shown to actually increase treatment retention. So keep this as an option as well. Some evidence that 400 to 800 milligrams of CBD can actually reduce the THC use, withdrawal, and craving. This is probably the most common thing I see when patients self-manage or self-treat. Particularly with withdrawal, they will find CBD a product that they like, and will generally kind of increase the dose themselves until they find that they're not craving it. There is limited evidence for naltrexone reducing the reinforcement effects of cannabis, so something to think about. And then, of course, always treat the co-occurring conditions, particularly with the mood disorders, depression, anxiety. If that's, a history of that, of course, co-treat them at the same time. There's always been a thought that maybe we should treat the mood disorder and then substance disorder, and that's never recommended. Always treat them at the same time, and that's going to create the most benefit and help the patient the most. And that is what I have. And looks like we have 5 minutes for questions. So I apologize. I was trying to give you guys 10 minutes, but.
Stephanie, there is in the chat, there is a question, a number of questions. I don't know if you could look at that and comment quickly for
Sure.
Mr. Balter.
So regarding orange peels, it's supposed to be TH free. I actually am not familiar with this. CBD from orange peels. I just want to make sure I'm understanding this correctly. So CBD can only come from the cannabis plant to be considered CBD. So I'm not familiar with CBD or derivative coming from orange peels, because it has to actually come from a cannabis plant to actually be considered CBD. So if I'm not understanding that correctly, please clarify. For the next question. So this is actually, so the question, can a physician be placed at professional legal risk by the federal government or other regulatory bodies for recommending CBD or THC for treating pain or other medical conditions? This is always a sticky situation. And the answer is yes, if the federal government wanted to. This has always been an interesting issue in states that have legalized it, because which one oversees the law on this? Is it the federal government or is it the state? And I don't have an answer for that. My husband's an attorney, and we commonly have discussions about this. And he generally says that the federal government trumps it, but that's not necessarily the case, right? Federal government it's a higher body of government, sure, but it doesn't mean that it can overthrow the state, right? That's why we have state laws. But I can't give you an answer for this, because this is a dilemma that we commonly see in states that have approved it.
I can answer that. In Nebraska, the way the Attorney General's office thinks of this is that they wouldn't step in, and they would consider, if the DEA took an action against the physician, they would not do anything to not support it. So technically, yes, we're at risk if we recommend this, in a malpractice setting as well.
Yep, absolutely. And, and as you mentioned, would they? Most likely not. But if the federal government decide to actually enforce this law, the state government essentially can't prevent the federal charges from coming forward. So you wouldn't be in trouble by the state, but federally you could. But would they do this? Unlikely, but always a possibility. Can chronic use, for example? So sure, yes. So as the research has shown that when consistent daily use at higher levels can essentially create this nausea when it's actually being used to treat the nausea. So the point of this is that when we're using it as side effects, especially like chemotherapy, it's not going to be it's not intended to be used long term. It's supposed to be used for the periods that the person has the nausea, and then there's a break. And then, when they go back to having their next round of chemo, then they would use it. So when we have that break in there, we generally don't have the worsening nausea. It's when we have this prolonged, consistent daily use that we actually have the effect reverse. And can long-term use of CBD cause side effects? Yes. At low to moderate doses, we generally don't see a lot of that addiction potential. When I say we don't have that high risk. That risk is still certainly there because everybody's reaction to doses is going to be different. So that moderate dose could actually be a high dose, and then we would actually see more of the side effects, potentially nausea, things like that. But when the effects are low, and it's a good product, it's got a lot of more of the research associated with it, so THC is low, then the CBD products generally don't produce as much side effects.
According to the expert medical source Google, there
Mhm.
is a Japanese company that is making CBD oil from orange peels. I don't know. That doesn't exactly, I mean, it's all over the place and you can buy it and it's allegedly wonderful, but I don't know anything about it. Some kind of weird cyclic terpene assembly. I don't know.
I have no idea.
I don't either.
I'm wondering how they involve the cannabis plant, because it's obviously maybe a synthetic that they actually put onto the
Yeah,
oil.
it probably is. I know. And they
But
probably
it's
do it without
interesting.
the consent of the oranges, but anyway.
That's
Whatever.
interesting. I would be cautious on it truly being
Yeah.
TH3 until we see more of the research, because the federal
Understood.
government says it can be up to 0.3%. So
Yeah.
would be my take.
Yeah, I agree.
All right. Well, thanks, Stephanie. Great presentation as always. Looks like we're at the end of our hour here. So there's a link to the evaluation survey in the chat. Also keep an eye out for an email from me in a couple hours with that evaluation survey to get your certificate. And like I said, we'll be off in March, back on April 12th. So keep an eye out for that next series of trainings. We hope to see you all back in April. And in the meantime, feel free to contact me if you have any questions, any patient issues come up. Always happy to connect you with one of our experts. Thank you and have a good day.